Hi, can you all hear me? Okay. Hi, good afternoon, everyone. It's my pleasure to introduce Dr. Sam Krishnamurthy. She's going to be speaking to us today on a good topic, living donors and kidney stones and groans and what to do with that. Dr. Krishnamurthy received her MBBS degree in King Edward Memorial Hospital and Seth Medical College in Mumbai, India. She then traveled here to the US and completed her residency at University of Louisville School of Medicine. And then she went on to have a few more years of training at WashU University in St. Louis, where she did her nephrology and transplant nephrology fellowship. Dr. Moorthy is now currently working at the University of Chicago, and she has special interest in access to kidney transplantation, preemptive transplantation, living donation, and genetics in kidney transplantation. She says that she currently has no concept of hobbies, and her spare time is all taken up by her 2-year-old daughter. And I get to see them sometimes in my neighborhood because we both live about a block away from each other. So I welcome Dr. Krishnamurthy, and she's going to give a wonderful talk today.
Thank you so much for that kind introduction. I chose this topic because whenever it's not every day that you have a living donor who has a stone or is at risk of stones that comes by. So the stones are in the living donor patients and the groans are from the transplant team because we always struggle what to do with them. And the larger the room is, the more nervous I get and the worse my jokes get. So please bear with me. So I always like to start with why it's important and why we're focused on living kidney donation. The whole transplant world is now focused on improving our longer term outcomes, having achieved excellent 1 year or short term outcomes. And as you can see, patient survival is excellent. 5-year patient survival outcomes in living compared to deceased kidney donors, and allograft survival also excellent 5 years out in living compared to deceased kidney donors. And another trend, which may be reversing now due to GLP-1 agonists, is the trend of worsening obesity. And all of this put together means that we're going to see more living donor candidates who are at risk or have metabolic syndrome and obesity in our clinics, who will be at risk or who have nephrolithiasis. And so we're only going to see this more frequently down the line. So I'm going to briefly describe to nephrologists what a kidney stone is. And then we're going to talk about what are the current trends in nephrolithiasis in the general population, current data on predicting stone recurrence in the general population, and then what is the current relevant evidence for kidney donors who are at risk of getting stones, what are the guidelines versus reality, and then why we need a personalized approach to this. So I've generously borrowed from Dr. Fred Koh, blog at University of Chicago. This is a picture of a kidney stone from an endourologic procedure, which is basically the arrow is pointing to the crystal or the stone that has formed on these whitish areas, which are basically Randall's plaques or sort of the root where calcification starts and then leads to stone formation. And then this is the stone, and this area is essentially the stalk where it was attached to a previous Randall's plaque. And another cross section, again, showing the stone overgrowing on the stalk on a previous Randall's plaque. And then majority of the stones are calcium oxalate followed by uric acid, calcium phosphate, and then less commonly struvite and cystine stones. So again, this is sort of in the general population, and this kind of spills into the donor population when they come in for evaluation. Now, in the first or sort of the earlier studies about prevalence of nephrolithiasis showed that the prevalence of stones was much lower, in 1 in 20 back in 1990s. And the first part of this, which looks at gender and age, the first 3 double bars are men, and then followed by women. And the men generally tend to have a higher prevalence or incidence of kidney stones. And then again, a racial difference in whites and blacks, where a higher prevalence was noted in whites. Now, on an updated study looking at the prevalence of stones, is now higher at average about 1 in 11. So it's about 10% for men and about 7% in women. And again, the lighter bar is men, the darker bar is women, and then as we move into the categories of overweight and obese patients, the prevalence of stones is going up. The other factor that's important for the future is climate change. There is literature that is predicting that the stone belt, which is essentially the southeast area of the United States, there's going to be northward migration of the stone belt. So there's going to be more areas in the Midwest and upwards that are going to be that are going to also be incorporated in that stone belt as the temperatures go up. So how do you predict that someone who's had a stone is going to have another recurrence, or how do you sort of predict their risk of recurrence? So different studies quantify this recurrence in different ways. The most common way is sort of symptomatic stone that results in clinical care. So that's how you have a group of patients that you follow, and then you see how many of them either get a surgical procedure or have a ER encounter or a hospital encounter for a symptomatic stone. But this approach misses a lot of other ways this could be happening. Another way in which studies capture how a kidney stone is recurring is a symptomatic stone that is self-managed, where you call patients and you interview them, and you have a recall bias in that they may have had something else happen, and they would have counted it as a stone. But the things that are not looked at in detail are recurrence on imaging. Many studies use a composite of recurrence and imaging and a symptomatic recurrence, but you could potentially define recurrence as a new stone that is now asymptomatic in someone who had previously passed a stone, or a asymptomatic stone passage. So they maybe had a stone and you re-image them and now it's gone. Or they never had a stone found on imaging, but they have passed stones. And then there's also stone growth. So someone passed a stone and they had another stone left in the other kidney maybe, and then now you re-image it 5 years later, and then you find that it's grown substantially. So DaCosta et al. Looked at a wider definition of what could be a recurrence manifestation. I like how they simplified this for those of us who don't think about stones every day, that their rule of halves. So they found that if you only looked at symptomatic recurrence, which required clinical care, it was about 19% in a cohort of 175 patients in Mayo Clinic in Minnesota and Florida, who were followed up at 5 years after their stone event. But if you also incorporated asymptomatic imaging recurrence, then that number went up to 67%. So essentially what they said is, among first-time symptomatic stone formers, half will have a remaining asymptomatic kidney stone, of which half will pass this stone in 5 years, of which half will have symptoms. So that kind of gives us an idea of what to tell patients who had symptomatic stones. Again, this is looking at the general population. The other well-known methodology to predict stone recurrence is Rock's nomogram, which utilized multiple different demographic factors like age, gender, race, family history of kidney stones, any gross hematuria, symptomatic hematuria, composition of stones, and the way, and then whether there was prior asymptomatic stone, etc. So all of these are incorporated. They're given different points, and then these points are plotted on a graph to help you predict what is the stone recurrence for this particular patient. So it gives a more personalized approach as to kind of predict a recurrence of someone. Again, though this is someone who's had a symptomatic event, so you would have to have had a symptomatic event to be able to use this nomogram. And further follow-up over many years, they showed that the more episodes you have, the likelihood of recurrence goes up. So once you had first episode, the likelihood of having a second episode goes up, third, fourth, and then so on and so forth from there. So what to do with incidental asymptomatic stones, though? There's not a lot of clear-cut guidelines or uniformity of how this is managed in the general population. So if someone has an ovarian torsion, they get a CT scan, and they're incidentally found to have a left kidney stone. A lot of decisions are made on the basis of the size of the stone. If it's 4 to 5 millimeter stone or bigger than that, what's the likelihood of the patient being able to pass it on their own? And generally, case by case discussion with the urologist is made to see if the stone needs intervention or if the patient is comfortable with just doing surveillance. There might be other situations, like if someone is a pilot, they have to have a stone out. They cannot even have any symptomatic stone. And again, the type of the stone, the location of the stone may determine if the surveillance is chosen, or intervention, or what kind of intervention is chosen. So there are a small number of studies looking at these groups of patients who have incidental or asymptomatic stones, but they didn't really differentiate between symptomatic patients who have residual fragments versus like people who've never had a symptom and just have an incidental asymptomatic stone on imaging. So again, not great quality data to understand these patients and what happens to them the longer you follow up. So does the act of just donating a kidney and having one kidney put one at increased risk of having a kidney stone? So a Canadian cohort of about 2,000 donors compared to a well-matched, healthy non-donor population of almost 20,000 showed that the answer is no. So living donors and healthy had about the same risk of a stone event compared to healthy non-donors. So that was very reassuring. So on the left side, the graph actually looks at rates of surgical intervention. If essentially leftwards risk is lower in the donors, and everyone's in the midline, so the risk is about the same. The only place where it was different was the number of hospital encounters. The risk was actually lower in men who donated versus the non-healthy non-donor male population had a higher risk of having an hospital encounter due to a stone. So again, reassuring data for donors who have donated. Seminal paper sort of talks about donor nephrolithiasis is out of Olmsted County, Mayo, where they followed over 8 years. They followed they looked back and saw how many living kidney donors who had been approved, and they actually differentiated them by who had symptomatic stones versus who was completely asymptomatic and just had an incidental stone. And about 1% of patients had a history of passing a stone and also had a stone on imaging. Differentiating these two groups of patients and comparing them to the donors who did not have any stones, the group that had symptoms from stones actually was more likely to have hypertension, more likely to have albuminuria and hypophosphatemia, whereas the group that had just incidental asymptomatic stone on imaging did not have these risk factors. So there was a delineation that maybe the symptomatic group has this higher risk of association with having metabolic syndrome versus the asymptomatic group. The other interesting finding was that, shown by the figure on the right, is that if you had a prior symptomatic kidney stone, then that group had a higher burden of number of stones, and they also tended to have larger stones compared to the group that was not symptomatic, which again makes sense. So what is the current data on stone disease after kidney donation? So these are a few series of single center studies. Again, you're not going to have a huge number of donor candidates with this problem. So Kim et al. Followed 16 donors with just incidental stones on imaging. They did not have any symptoms. And they found that at about 1 year follow-up after donation, none of the donors had any stone events. Olsberg et al. Had a bigger cohort of 20 patients where they also did ex vivo ureteroscopy in about 17 of these patients. So after donor nephrectomy, during backbench preparation, they put a ureteroscope and they removed the stone in about 17 out of these 20 patients. And again, a median fall of about 2 years or so, they did not see any stone events in the donors or recipients. And then Riscala et al. Had a larger cohort compared to all of those of about 54. And they also had included patients who had symptoms and had incidental stones. So it was a slightly more mixed group of patients. They did have one donor stone event at 1.8 years, but that stone was only 2 millimeters, and still the donor had an event. So one would have thought it would have been a bigger stone, but it wasn't as such wasn't anticipated to happen. Serur et al. Have the longest follow-up that has been published, which is at about 6 years follow-up. They haven't had any, donors did not have any stone events, but this was again limited to patients with incidental stones only. Sarval, which is the most recent series, mixed up both patients who had symptoms and who had stones, and again, no donor events at 1.5 years. But again, you can see this is maybe not long enough. Like if someone's donating at their age of 40 or 30, they could be having a stone event later in life. And then not all patients in these series had 24-hour urine testing. There was a certain percentage that had urine testing. So there was a little bit of lack of uniformity from that aspect. So, and then the other important thing to look at in donors is, as we know in the general population, having stone disease is not just about stone events, but it's about the increased risk of chronic kidney disease and other comorbidities that these patients have. So Murad et al. Looked at, compared donors with kidney stones without kidney stones, and had a very long follow of about median 16 years to see if there is hypertension, albuminuria, CKD risk that increases in this group of donors who have stones, and the data was actually reassuring. So the first panel, A, is looking at hypertension, the second at proteinuria, third at EGFR less than 60, EGFR less than 45, and cardiovascular disease, and all of it was statistically not significant. So again, reassuring data that long-term, at least the information we have so far, there's no harmful effect on a donor with stones who is donating. So how do we approach a donor who presents to the kidney transplant clinic and has a history of stones, or is at risk of stones formed in the future, or simply has an incidental stone on imaging that they did not know about. So you have to balance what is the risk to the donor and recipient. And the obvious risk to the donor is an obstruction in their solitary kidney. So majority of the times we try to pass on the stone kidney to the recipient, and try to assess the risk of stone recurrence in the donor. The other thing to make sure is look at their other risk factors. What is their BMI? What is their blood pressure, their cholesterol? Are they falling into sort of this metabolic syndrome picture? And what is their overall risk from donation? And then there is always, if the stone is given to the recipient, then there is a risk of recipient recipient can have a stone event and pass that stone post-transplant as well. And some centers mitigated by having the urologist take out the stone at the time of backbench preparation, but there are also case series from single centers showing that this happens as a rare occurrence, and majority of the times it's perfectly tolerated by the recipient. And then there is benefits to the recipient, which is very obvious because for every living donor who donates, there is someone else on the wait list who can get a kidney. And that person who's getting a living kidney gets the chance to have really excellent long-term allograft and patient survival. There's psychological benefit to the donor if they want to donate to their child or their loved one, and they are being denied as a candidate because of having a stone or being at risk of stones. And then I'm going to present an interesting case, and hopefully in the future we'll have data that actually donating a kidney might reduce potential reduction of stone risk in the donor. And guidelines, all the guidelines, if you note, ask for a stone metabolic panel. They might have different choices about the sizes and the grammar used in their sentence, but essentially they're all asking for a normal or negative metabolic studies or urine metabolic panel, which is normal. There are Amsterdam guidelines actually says to exclude bilateral stones, but there's really no data anywhere saying that bilateral stones need to be excluded. Many centers do utilize based on the patient's individual risk factor. And then a lot of these bodies do not really have a sort of position on whether you should do the ureteroscopy and remove the stone before donation or not. And there's really no recommendation on what is a negative metabolic workup or what is the threshold. What would you consider a normal metabolic workup? So you could take the same 24-hour urine study to different centers and come away with different opinions. So even though all the guidelines say that you should be doing 24-hour urine metabolic workup, nobody really tells you what the thresholds are or how to manage these or what is the right way to follow up on these either. And this is survey in transplant where we get surveys once every 2 weeks. So only about like 13 or 15% of the programs actually responded. But there are still, so this is from 2020, and there are still 10% of programs that said that they would decline all stone formers, which I think is not fair because they would just decline them from the start and not even consider them. All of them have their own stone size cutoffs. There's really no logic to it. And then like many things in transplant. And then maximum number of stones allowed is also different, and follow-up interval after a stone event is also different. So there's clearly sort of whether you get approved if you have a stone or you've had a stone or you have a stone on your CT scan, and whether you're going to get approved or a donor or not depends on which transplant center you go to, because one program might say no and the other program might have a completely different approach to it. So that's where, like, even though the guidelines are there to get us to sort of follow the same pathway, everyone's doing whatever they want, essentially. So we looked at data between 2011 and 2021 because we have a kidney stone program at University of Chicago, and wanted to see what have we done over the last decade, and how we've managed these patients, and to kind of take a look back at our data. So our rate of patients having kidney stone was, or being at risk of nephrolithiasis, was about 9.7%, so close to 10%, similar to the other series. And we sort of, there were about 51 out of 73 who had incident nephrolithiasis, and there were, the smaller group was patients who had symptoms, and then we further divided into those who had bilateral and unilateral. So many people actually don't make it because the donor process is so arduous that we found that the stone evaluation itself was a barrier for a few patients, and they kind of didn't want to do the 24-hour urine, or at that point they thought it was too much and they declined. And then many patients are lost to follow-up, declined due to other causes. Eventually, a few patients trickle down to the kidney stone prevention clinic, where they have this 24-hour urine study, usually 2 collections, before they see the nephrologist. And then few were accepted because they had completely normal metabolic profiles. Few were accepted after a certain amount of counseling, though they didn't need any intervention. And then some required conditional acceptance pending intervention, and then some were declined right away. These were patients who had gastric bypass with significant hyperoxaluria, or some with persistent hypercalciuria with renal tubular acidosis. And if their intervention was successful, they went ahead with donation, of which we were successfully able to donate. And then if they were not successful and they had these persistent high-risk metabolic features in their subsequent urine collections, they were declined and asked not to donate. And then we also found cohorts of patients who had bilateral nephrolithiasis, who could have potentially been donors, but were declined just purely because they were bilateral nephrolithiasis. So after this, we actually changed our protocol, and now we also consider bilateral nephrolithiasis on a case-by-case basis, because a lot of these patients did not even make it to the stone evaluation. So we changed our approach because of looking at the rest of the data. So this is sort of an example of average findings in patients who were approved right away and who did not need a lot of interventions. Essentially, their BMI average was around 27. They had good urine volumes. They had normal supersaturations, normal calcium excretion and high citrate in the urine, and low oxalate. So these patients usually, if any issue, it was low urine volume, and they were asked to correct their urine volume. They didn't really need repeat samplings or follow-ups. And these were like a mix of patients who had symptoms and who also had just incidental stones. And then this is a patient who actually donated, after an intervention was done. And so at the first visit with the kidney stone program, they were noted to have hypercalciuria. And they had a stone event 8 years prior to presentation to the transplant clinic, and a 2-millimeter incidental stone on the left kidney. And they underwent dietary counseling with a renal dietitian on low sodium, low oxalate diet, because the oxalate was also high. And they were prescribed a thiazide. After intervention, things improved, went on to donate. And you see 6 months post-donation, their hypercalciuria is significantly improved. And talking to Dr. Zisman and Dr. Ko, who have been like following some of these patients, they attribute this to the decrease in GFR itself, which decreases the hypercalciuria. So it's even more, the improvement is even more pronounced after donation. And then they've continued to maintain a low sodium diet. and oxalate. Now, I also cannot eliminate the bias that they're following up in stone clinics. So the stone clinic effect is always going to be there. But it was interesting to see that. And then this is an example of a patient who was declined. He only had a punctate stone in the left mid kidney, but had high hypercalciuria, and despite having high citrate in the urine, continued to have even a higher oxalate even after interventions to change their diet. So no matter what they changed, their hypercalciuria persisted. So this patient was actually declined, even though one would think they only had a punctate stone in one kidney. So using the 24 metabolic urine panel, we were able to sort of risk stratify them as higher and not just followed them just on the basis of imaging. And then we also had a patient who was declined by another center and had, because of having bilateral punctate stones on both sides. Last stone event was 9 years ago, and actually all of their urine collections were completely normal. But our transplant, basically the surgeon and the program declined them because at that time, that is what our protocol was. But this is someone with close follow-up could have potentially donated to their elderly mom who probably would not have been able to wait long enough on a deceased donor list. Um, so, um, so what we realized is that we don't have enough numbers because these patients are so few. And over the last few years, we have some numbers, but not enough to see that if we can show some statistical significance when we analyze the data. So we teamed up with UAB, where their urology and transplant group was also looking at the same data. And our pool data and UAB's data gave us enough numbers to actually look at these patients. The big difference between our center and their center is that their patients don't go to a stone clinic. They are managed by the transplant center themselves. And essentially, we found the average age was about the same. The racial distribution was about the same with a pretty good diversity, and the BMIs were around high 20s. Um, and what was interesting that when you compared the patients, just looking at the pool data, which is the first three columns, approved patients had lower hypercalciuria. Patients who were rejected had more hypercalciuria. Similarly, those who were rejected had more supersaturations of calcium oxalate and calcium phosphate. And then our data by itself only almost reached statistical significance for hypercalciuria, but combined, we were able to show that the patients who, again, we're not showing anything massively new, but we're able to show our approach in that we're both sort of following the same guidelines, and we're able to show that we're only approving those patients who have less, who don't have hypercalciuria or high supersaturations. And then we compared patients who were approved. We compared what their first collection and what they did after intervention. And we found that after intervention, there was significant improvement in their calcium and in their supersaturations and urine volumes as well. So these were sort of the common findings between both our groups. The other group that has published data on 24-hour urine volumes is Sarwal et al., but they did not use continuous distribution. They sort of just looked at high calcium, low calcium, high supersaturation, low supersaturation. They didn't really find any statistical significant difference between their kidney stone donors who donated and who did not donate. So they didn't find anything significant. So this was the only other sort of data point that we had. So now I'm going to go into detail about each and every electrolyte in the urine 24-hour panel. I'm kidding, I'm not gonna do that. So, so the pros and cons of a 24-hour collection are, there is actually people who do not like the 24-hour collection because it's so hard to do, and the philosophy is why not just have everyone drink a lot of water, put them on a thiazide or give them citrate and just see what happens. And so the transplant guidelines don't support that. As you saw, every guideline does want a 24-hour urine sample. And there is data to show that selective therapy is better. So the blue bars are people who just got empiric therapy, and then yellow bars are patients who got selective personalized therapy based on their 24-hour urine. And they all had less ER visits, less hospital admissions, less procedures, less adverse events, and less recurrence probability over a long follow-up time. Again, the bias of following up in a stone clinic, getting reinforced about good dietary adherence and medications, that bias is always going to be there. But really, again, borrowing from Fred Koh's blog, stone prevention is very precise, personalized medication because each person, the reason why they form certain crystals, why over a lifetime they might form calcium oxalate in the beginning, calcium phosphate later. What do they do? Are they a OR nurse who works in the OR for like 10 hours and cannot leave? Are they someone who's working outside in hot weather? Are they a glass blower who is around like high temperatures? So not just the 24-hour urine, but actually taking a very deep history and really understanding their lifestyle is actually what makes the difference. And I think I have the luxury of having our stone experts do that for us because not everybody in transplant really understands stone or understands the way one has to approach history taking for these patients. So the lessons learned from this are that there is a need for consensus and evidence-based guidelines in selecting living donor candidates. Just having isolated low urine volumes, hypercalciuria and hyperoxaluria to a degree are not absolute contraindications to donation. And then hypercalciuria improves after donor nephrectomy, but that's something hopefully I will be able to prove over the next couple of years. And then candidates with bilateral nephrolithiasis can actually be considered if their current risk factors have changed and they're able to show that they can modify the risk factors. But the catching point in donors is always the ability to have good follow-up. So I think we have to choose these patients very carefully on the basis of whether they can actually follow up. And then just the fact that there are some people who have abnormal, who are going to have no stones and have abnormal 24-hour urine panels. And that's a way to catch if someone's having increased sodium intake, oxalate intake, and it's a different way of looking at donor health as well. And if they're already giving a 24-hour urine for creatinine clearance, one wonders if also checking electrolytes would help them actually get to a healthier lifestyle, since that's what we want them to do after kidney donation. So thank you so much. This is where I end, and I'm happy to take any questions. Please don't ask me about urine electrolytes.